All right, so now we're going to continue on with our treatment of CF and controlling the infection with going into antibiotic therapy. Both the clearance of airways and immunizations are prophylactic, trying to avoid infection. The antibiotic therapy is once we have an exacerbation, how are we going to help the patient fight off these bacteria? Well, first of all, you need to know, as I've mentioned before, these kids and adults now are hypermetabolic. They are in a constant state of stress because they have constant inflammation and are really always have infections. They are lower and higher level at different times, but they're very hypermetabolic, which means they have higher clearances, which means you have to increase doses or dose rates. And what else? We also have to decrease dose intervals. So we have to give more drug more often and usually for longer. So you will see very large doses of these drugs given to patients, and it will freak some people out if they don't realize that it's a cystic fibrosis patient and understand that you have to give higher doses and dose rates and you have to give it more often because of that increase in clearance that you see in these patients. You understand increase in clearance will decrease CSS average, therefore we have to increase dose rate. And it will also decrease half-life, therefore we need to give it more often and decrease the tau. I know you guys know that. So anyway, make sure you know that. That's another thing that pharmacists need to understand. There are now, we often give these drugs IV, but we now have several drugs that are available in the aerosolized form, which is great because you don't have to expose the whole body to the drug and to the toxicities of the drug and to the resistance that it causes. You can just give it directly into the lungs. The first one that was available is Toby, which is, you might have guessed, tobramycin. Aztreonam is also available. Colistin is available as a investigational treatment. But, and there's also some studies for other antibiotics to be given in the aerosolized form. And these are very expensive, but you need to know how to, if you ever work with CF patients and need to give them, you need to understand how they're given. They're kind of a little different. In some cases, with the colistin, the patient has to mix them themselves. The question might be is it worth giving these drugs prophylactically? Well, there was a study on that because the problem is if the patient gets colonized with Pseudomonas, there's a lot of destruction of lung tissue. So you want to avoid colonization with Pseudomonas. So we looked at giving tobramycin or other drugs prophylactically to try to avoid colonization. Well, that didn't work. They just got other bugs instead. So we don't give prophylaxis against those kinds of things, but we do give other prophylactic drugs. But one of the things we found is that an early treatment of Pseudomonas is very useful. So if a patient for the first time cultures Pseudomonas, we treat it very aggressively. You can switch it so that it's not a chronic mucoid infection, which ends up poorly for the patient. So we give inhaled tobramycin or colistin, usually tobramycin, with oral ciprofloxacin or Cipro or inhaled alone right away. And if we treat them very aggressively, this is a small sample size, of course, but in 14 out of 15 patients, they were able to eradicate the Pseudomonas. So that's kind of an important piece. As you know, infection and inflammation are kind of a vicious cycle. The patient has an inflammatory effect, which brings in the inflammatory response, which can cause a massive influx of neutrophils into the lungs. And even in mild CF, they're going to have 100 times more neutrophils in the body. Remember, the neutrophils are like, the infantry in the body. So I always think there's all these cytokines and different or interleukins and tumor necrosis factors, which are chemical bugles that say, come here, we have a fight on our hands. We have to eradicate these bacteria. So these buglers call in the neutrophils, and the neutrophils rush into the lungs, and then they're ineffective and they die there, and they clog up the lungs even more. So that's not good. So they have excess neutrophils and excess with the cytokines, oxidants, proteases, and elastases that are all there to help fight the infection, but end up causing damage usually due to this inflammatory response. So we've got this vicious cycle of lung disease. We've got the gene mutation, therefore the CFTR doesn't work, therefore the ion transports don't work. Then you have altered airway secretion. This is in the lung, which cause infection, tissue damage, and inflammation. And then this is a vicious cycle that ends up damaging the lungs and causes death eventually. Inhaled tobramycin, I'm not going to spend any time on this, but you can see you give it twice a day for 28 days. They usually have a month on and a month off if they've got a chronic infection. I think I talked about prophylaxis already. Okay, that's it for antibiotics.